So thank you for joining, everybody. Hopefully by the end of this presentation, you will have a holistic way of viewing dementia and a good understanding of what the final stages might look like for different people. I do not have any conflicts of interest. Always like to start with a case story. So a few of the details have been changed to protect this person's anonymity, but this is very much both a typical and a real person. So Bob, somebody who I met, he was mid-80s and admitted to the geriatric psychiatry unit. He was referred by an emergency room because he had severe aggression towards staff and peers. He clearly had advanced dementia. Anybody could see that, but he was up and walking and interacting and picking things up and moving around. When we talked to the family, they reported a 25-pound weight loss over the last 3 months. On the unit and by history, he really showed no interest in eating, and his speech was quite minimal. He had a few words here or there. The main word that he ever said was no. And I was the attending geriatric psychiatrist for Bob, so I was in charge of working with him and the family. And his family were shocked and surprised to hear from me that dementia was a fatal illness and that Bob was close to the end of his life. And so ever since this happened, and it actually happened multiple times, I've made it one of my missions to help healthcare providers do a better job of explaining what dementia is and working with families so they aren't surprised and that things aren't as advanced as this before people realize that dementia is a fatal progressive disease. I'm going to review some specific tools during this presentation, the PAIN AD or advanced dementia, as well as the mini suffering state exam. I'm going to review neuropsychiatric symptoms, sometimes called behavioral symptoms. I'm going to review which ones are responsive to non-pharmacological interventions, which ones are responsive to pharmacological. As well, I'm going to review appropriate use of medications, including dementia-specific medications. One of the key things that we see when we study death certificates is that all of our hard work to decrease death from cancer and heart disease is slowly having an effect. All of the work we've done to control people's blood pressure has really decreased the risk of stroke. And a lot of infectious diseases, and hopefully one day COVID-19 itself, have been decreased significantly as causes of death. But what we have not done is decrease the number of people who are dying related to dementia. And that's really a twofold thing. One is the more successful we are at treating other causes of death, the more likely it is you are to live long enough to have dementia and have it as a contributing or main cause in your death. Just some brief overview about some of the statistics for Alzheimer's disease. And these are actually by now a little old, but most of them have not actually changed. It is the 6th most common cause of death in the US, and it's the 5th most common cause of death for those who are 65 and older. It is the only current cause of death among the top 10 that cannot be prevented, cured, or slowed. And one of the reasons that I like to talk about suffering in the context of dementia is not because I want to encourage suffering, but because I think it's very important as human beings that we recognize other people's suffering. And when we start from that place, it's very easy to have an immediate alliance with family members and with people who have a diagnosis of dementia themselves, as well as other staff. Nobody is in healthcare because they want to see people suffer. The vast majority of people come to healthcare because we want to decrease suffering. And acknowledging that suffering is really key to acknowledging a person's humanity. Keith Oliver is a fellow who had early onset Alzheimer's disease, and he actually has a website called the Dementia Diaries, and they're recordings from actual human beings who have diagnosis of dementia. And there's all sorts of recordings. Keith died a couple of years ago, but one of the things he said that really struck me as important when I'm working with patients and families is that information is important, but not too much information, and not too much information at one time. And he also wanted to make sure that people understood that dementia was so much more than memory problems, that in fact, the memory problems, although they can be very severe, they aren't even the main part of the problem with dementia, even though we still think of it as a memory disease. I want to encourage people to consider offering palliative care at diagnosis. And I want to really, I think that we need to start thinking about palliative care, which is not hospice care. Palliative care is an approach to care where you want to minimize people's suffering. And I think it's really important as healthcare providers, anybody who works with older adults should have conversations about this throughout a person's life. Every time a serious illness is diagnosed and every time a serious illness worsens. And it's a great time to discuss advanced directives so that people can have the kind of care that they want. And when somebody gets to a point where they qualify for hospice or a PACE program, a program of all-inclusive care for the elderly, that is a great way to get more support for a person and their family. But those are very separate from palliative care, and the palliative care hospice part is really something when people have a very fixed prognosis, you know, when we know that the end of their life is most likely in the next 6 months. So when do you consider palliative care? Well, there's really no bad time. It's a great time to consider palliative care. But sadly, what we see too often is that death is actually imminent before people even talk about it. One way for us as healthcare providers to get into better habits is to have triggers built into an order set on a unit protocol or into an electronic health record. That's a great way to help healthcare providers shift their habits so that we consider and discuss palliative care earlier. So triggers for discussions are something that electronic health records use frequently. And there are a lot of advantages for them. They help us deliver the right care at the right time to the right person, which is called the triple aim for quality healthcare. And they also support a holistic person-centered approach. So just as an example, a lot of people think of your heart as a common reason that you die, and that certainly is true. When do you want to think of palliative care for somebody who has heart failure? Well, the first hospitalization is a great time. When people start having trouble doing their activities of daily living, if they have other medical comorbidities, or if their ejection fraction is less than 30%, or there's some other medical reason to think that their disease is going to progress quickly. It is really imperative to start talking about palliative care once somebody gets to a second hospitalization. If somebody doesn't have advanced care planning documented, that is very, very important. If families or a person needs emotional support, if there's caregiving issues, or if there's trouble with symptom management, those are all good reasons to consider palliative care and start incorporating that into your discussions. Oncology uses the surprise question. And so if you talk to an experienced provider and you say, would you be surprised if this person dies within 1 year? If the answer is no, I would not be surprised. That, it turns out, is one of the most accurate ways to get a prognosis for a person. It may not qualify you for a hospice stay, but it is a great question to help cue you into talking about palliative care. And then other things, somebody who used to come into clinic but can't come in anymore, somebody who has had more than one hospital or ED visit in the last 2 months, somebody who has difficult to control symptoms, and somebody who needs help with advanced care planning discussions. So let's talk about end-stage dementia. You know, you'll notice that on this slide, I've highlighted difficulty swallowing and eating, weight loss, and aspiration pneumonia. Those are really, really key. But other things are noted too. People tend to have increasing infections as their immune system fails. So if we look at dementia as brain failure, whenever you have a secondary organ system that fails, that's a good clue that things are nearing the end. So infections, frequent infections, are a failure of immune function. The parts of the brain that are key are difficulty walking or frequent falls. People actually misunderstand, and they often think that people with dementia die because they have the fall. But what actually is true is that people have falls because they're nearing death. If you need help with toileting, if your language skills go down, or you lose the ability to smile and you have decreased facial expression. So what do these symptoms mean to you when you think somebody is sad, or when they're crying, when you see somebody pacing with clenched fists, when people with dementia start to hit or push you away, when people with dementia start to call out or scream, when people who have dementia are inconsolable? Well, here's what I would suggest that you start to think about. Pain. Pain is almost certainly an underlying symptom in people who have advanced dementia. And as a matter of fact, I recommend the pain AD scale in everybody who has a diagnosis of dementia. Most of the people who we diagnose with dementia are actually already into the moderate stages. They already have notable functional impairments. And when you have these kind of impairments, people's ability to use language and understand language to really communicate well is very impaired. And that's why asking people, are you in pain, is sort of the least effective way of finding out if somebody with dementia is in pain. The pain AD scale is a much better way. And so I just sort of circled some of the symptoms. These are often called aggression or behavior disturbance. But if you see this, if your pain AD score is 5 or more, it is time to consider the use of palliative care and medications for pain. Adequate pain control cannot be overestimated, the need for it. It is so important. Because if somebody is in pain, it's just like when we have severe pain at any other point in our life. When you have severe pain, you really can't think of anything else, and you can't really do things. So other interventions that you're trying with a person aren't going to work well if they have untreated pain. So common misleading pain presentations. You know, I think we are so worried about the diversion of opiates, which I definitely think we need to pay attention to, but the time to pay attention to that is not when you're working with someone who's nearing the end of their life. And so it's really, really key to pay attention to that. And if you look at what does end of life look like for people with different disease states, you know, that top diagram is most people with cancer, and that decline is actually often days or, you know, a couple weeks. The average length of stay in most hospices is 2 weeks. And that's because That's when people kind of fall off that cliff and they get referred. People who have heart failure or chronic obstructive pulmonary disease, COPD, or chronic obstructive lung disease, that middle graph really is what you see there. So people tend to have exacerbations and they recover somewhat, but they never get back to the previous level of functioning. Frailty and dementia is really part of the end of that trajectory and the end of that. So it's just much harder to predict, and it's just sort of happens so slowly and so gradually that it's very hard to see it in the day-to-day life. The number one barrier to referring people with dementia to hospice is physicians and other healthcare providers have challenges with assessing prognosis. And they really identify that as the number one barrier. As well, we are often in certain parts of the country and certain parts of the state, we are not in a spot where palliative care is integrated into primary care. And that's actually the best place to deliver palliative care for someone with advanced dementia, when they're working with the healthcare providers who know them and know their family and have known them for a long time, rather than a specialty palliative care setting, which makes less sense for this kind of a disease. So hospice uses something called the FAST. The challenge is that it's not very accurate, and it really only tends to get a certain small segment of people. And so what I recommend is a simpler tool called the mini suffering state exam. And it's 10 yes or no questions, which I like because it's simple. And it also really focuses on things that are symptoms that cause or are caused by suffering. And I really think alleviating suffering needs to be our focus and our goal. So not being calm, screaming, having pain, and I think the pain AD is a great way to measure that. When people start to have decubitus ulcers, or what we now call pressure injuries, when those start to develop, then that's really failure of your skin, which is your largest organ. So then you have both brain failure and skin failure. So you have multi-system organ failure. And I'm not sure that we always recognize that that's what pressure injuries can represent, and most often represent in people who have dementia. Malnutrition, eating disorders, a need for invasive action, which certainly any sort of trip to an emergency department or a hospital is very invasive and usually very disrupting to somebody with dementia. Anybody who needs frequent blood tests or IV fluids or transfusions, etc. Having unstable medical conditions, because once you have dementia and brain failure, you're just really at risk of dying with any other contributing factors that you might have. And then finally, suffering in the medical opinion or the nursing opinion, which of course is subjective, but it is from a healthcare provider who's seen a lot of patients. And is the person suffering in the family's opinion? And if you add up with 1 point for every yes, and the score is 7 to 10, then that indicates a high level of suffering. And the nice thing about this fairly easy to use tool is that it does correlate to the end of life in people with dementia, and it's much more effective than the FAST scale. So I really highly recommend its use. I'm just going to briefly review a project to integrate palliative care into primary care clinics from New Mexico. You know, they noted that it was very difficult for people with non-specific diagnosis to get access to palliative care, and people didn't really have access from palliative care specialists until they were near the end of their life. So they looked at their data, they integrated and did education with all of the primary care providers and actually all of the staff in their medical homes. You know, they had a medical home model of care. So they had primary care clinics that had social workers and nurses, as well as medical assistants and receptionists. And they actually did education with everybody about what palliative care truly is. So after they integrated this, what they saw was a significant increase in home visits. The most common diagnoses were people with dementia or sort of what we sometimes call failure to thrive, and people who had cancer, but that cancer was not being treated by an oncologist, sometimes because it was so advanced, and sometimes because the person wasn't interested in an oncology referral. And so they saw a significant qualitative improvement in patient and family satisfaction. And so I thought that was quite important. And when they looked at costs, what they found was by integrating palliative care, hospitalization costs dropped significantly, emergency room costs for emergency room visits that weren't actually helping people with the real problem that they had dropped significantly, and outpatient hospital service utilization also went down. So when people and their families had a realistic understanding of the course of the illness that they were experiencing, they had more appropriate use of healthcare and less inappropriate use of healthcare. So I'm going to divert for a moment to psychiatric symptoms that are amenable to treatment with medications and psychiatric symptoms that are not amenable. So we have sort of shifted from the part of the talk about palliative care specific to those people who have dementia. And now I'm talking about the neuropsychiatric behavioral type symptoms that people with dementia often have. So certain symptoms respond quite well to medication. And this is sort of the list here. Paranoia and delusions. Hallucinations tend to respond fairly well. Depression, if it's major depressive disorder. However, if it's sadness because you're dying or you have an illness, or it's apathy and a decreased interest in the environment, those things do not actually respond to medication. So a major depressive episode type illness does respond. That kind of depression does. Others don't. Anxiety, if it is an anxiety disorder, it also often responds to medication. However, if it's anxiety because you're dying, there's really no medicine that's going to fix that. Pain is definitely very treatable, and I definitely recommend always starting bowel meds whenever you start pain meds. And then aggression, if it's not responsive to antipsychotic medication, which is the #1 medication that is effective for notable aggression in people with dementia, then it is most likely the aggression is a sign of pain or nearing the end of life. And I think that is very much under-recognized. What doesn't respond to medications? Well, some of the most common things that people try and medicate away unsuccessfully are wandering, because there's another word for wandering, that would be walking. And walking, you know, we all learn to do it when we're around 2, and we do it from then on. And that is not really treatable. Calling out, if it's not pain, which most often it is, but that repetitive calling out, really consider if that is just significant brain failure, and that is good evidence that somebody is nearing the end of life. Sometimes repetitive questions where somebody asks the same thing over and over is kind of related to the calling out. It's when people, their brain sort of gets stuck because most of the brain isn't working and they can't go on from that to another topic. Anxiety, because you have a brain disease, there's no illness for that. Psychomotor agitation and restless, unless it is from pain, really, again, that's one of those times where I highly recommend considering end of life. For people who have sleep problems, much of the time, we always try and treat them with medication. They're often not responsive. What's much more efficacious is increasing a person's exercise, especially early in the day. Access to early morning light is very important too. So what about dementia-specific medications? Well, there are no recent guidelines in the United States, and there's a long history and reason why that is, that I won't bore anybody with. But in 2015, the European Academy of Neurology recommended combined treatment with cholinesterase inhibitors like donepezil or Aricept, rivastigmine, Exelon, plus memantine for people who had moderate to severe Alzheimer's disease. And specifically, they recommended using those things for behavior disturbance. They noted that there was good quality evidence to support their use for that. However, there was not great evidence for their use in reversing cognitive function, and there was moderate evidence that they might support cognitive function. So really, their overall recommendation was weakly positive, but that really obscures the fact that for anybody who has dementia with behavior disturbance, that is an excellent reason, evidence-based reason, to use the dementia-specific medicines when the kind of dementia is Alzheimer's disease, Lewy body dementia, or Parkinson's disease dementia. So, and specifically, we have evidence that the cholinesterase inhibitors effectively treat psychosis, agitation, paranoia, delusions, apathy, and depression, and that memantine helps sleep, appetite, anxiety, agitation, and aggression. So I often get I get doubters in a medical audience when I talk about dementia-specific medications, and that's really because there's so much evidence that talks about dementia-specific medications in the context of cognition and memory. And we really don't have great treatments currently for cognition and memory. But what we do have a significant body of evidence for the dementia-specific medications is around behavior disturbance. And so I think of dementia as kind of a disease state that has three legs. One leg is cognition, one leg is behavior, and one leg is functioning. Day-to-day functioning with your independent activities of daily living and then your activities of daily living. And so what we know about behavior disturbance is that if people with dementia live for 5 or more years, the incidence of behavior disturbance is 100%. So the other thing that we know is that a good percentage of people actually present with psychosis in the year or two before they're diagnosed with dementia, as well as depression and anxiety. So for many people, the behavioral symptoms, the neuropsychiatric symptoms, actually present prior to the diagnosis and prior to the cognitive functioning. But so here are some of the many studies on dementia-specific medications and the use for behavior disturbance. I want to take a slight diversion here to talk about aggression. Well, when is aggression most likely to occur. This was a study of a nursing facility in Norway, and it was actually a very well done study. And what they found were there were 2 times when aggression was most likely to happen. It was almost always related to denying a person something, telling them no, or taking something away from a person. And if you think about it, if you're a confused person, you have dementia, so you can't really understand a rationale and the reason people are doing things. When they deny you something, when they tell you no, most of us don't like to hear no. And when your brain is impaired, you really don't like to hear no. And then finally, when somebody takes something away from you, the common word we use for that is stealing. And so the that's one of the challenges with taking something away from somebody who's really confused and has dementia. They're not going to understand the bigger context. They don't understand that that actually belongs to somebody else or might be dangerous for them. And then finally, went with personal cares. And personal cares, helping somebody toilet, changing a Depends, all of that is really important. But from the point of view of the person with dementia, it can definitely feel like they are being attacked. And so it's understandable. It's what I call provoked aggression. I really apologize that I thought I closed that window and I didn't. So what they also found in the nursing facility was that the majority of incidents were with a very small number of people, and that there was very little injury. Now, I'm not saying that there's never injury. I certainly have seen staff members who have been injured by someone with dementia, but it is very, very unusual. So I don't want to minimize its importance, and I think we need to pay attention to staff, and it does matter. Their being in danger absolutely matters, but I also don't think we should overemphasize the danger. And what they found in Norway was the most frequent intervention to diffuse the situation was talking with the person. But I want to highlight here, it's not talking to the person with dementia and explaining things to them about why they're wrong and why they need to change. Actually, the purpose of talking with the person is to divert their attention to something else. It's to distract them. It's to soothe whatever underlying problem they have. It's to help them leave that room and go to another room. Actually, one of the most helpful things you can do with someone with dementia to distract them is to ask them to help you. Most of us actually like to help other people, and many of us, especially men, don't like to be helped. And certainly most of us don't want to need help. So actually, when you ask somebody to come over here and help me, a lot of times a person with dementia will drop whatever it is they're doing and go over. And it really is a very person-centered intervention to ask people to help you. There is good evidence for using antipsychotics to treat psychosis and agitation or aggression and dementia. And there's a lot of confusion about this. And I'm going to talk a little bit about what we have good evidence for. And once the FDA put warnings on the atypical antipsychotics, and then a few years later on the typical antipsychotics for this association, not causality, but the association with use of antipsychotics and death in people who have dementia. There have been almost no studies since that point in time. So we only have older studies, and those studies would not include any of the more recent medications. What we have is good evidence for risperidone and aripiprazole in treating psychosis. That's delusions and hallucinations. And we have good evidence for using risperidone and olanzapine to treat agitation and aggression. Um, and just as an example, everybody always wants to decrease medications where they're not needed. But what we found, certainly those of us who in practice, was then shown in a study. When you have somebody who has aggression or psychosis that got better with risperidone, if you take it away, their symptoms will come back. It's not 100%, but it's a very, very high rate of relapse, especially with a very short time of treatment. So, and I think that's because the agitation, aggression, and psychosis are almost always signs when people are nearing the end of their life and they have significant brain failure, significant damage to their brain. And because of that, that's why when you remove the antipsychotics, all the behaviors come back. That's the most common reason. I'm just going to briefly review here Ruby. So not her real name, but it was very striking to me when this happened. So I was talking to Ruby and her professional guardian in my office. Ruby herself was sitting there in a wheelchair. She could talk. She was quite a little talker, but other than the social benefit of having a conversation, all of the information she conferred was very old and none of it was accurate. So I could ask her what she did that day and she would tell me what she did that day, but none of it had happened anytime in the recent past. So her conversational speech was normal, but she was not in a spot where her brain functioning was normal. Her brain functioning was very, very impaired. She wasn't eating well. As I talked more and more to the guardian, then I heard about the pressure injury, the decubitus ulcer. I heard about the pain. I heard that she'd had an admission for dehydration and another admission for a UTI. And then I looked at her lab work and her albumin, which measures your oral intake, your protein intake, was really very, very low. Then I talked to the guardian about Ruby suffering. And I asked the guardian if she thought Ruby was suffering, which she did. And I certainly, anytime you have to have interactions with the medical professional, as good as we may be, we do cause lots of suffering with all the things we do to people. I pulled the mini suffering state exam out. I scored it for Ruby. She scored 7. I talked to the professional guardian about how Ruby was really in the last few months of her life. The guardian was astonished. I talked to the guardian about how important it was to talk to Ruby's family because they were pretty distrustful of many things. And I didn't want them to be surprised when Ruby died, because no matter what we did for Ruby, her brain failure, her skin failure was very advanced, and there wasn't really anything we could do that was going to change that. We could make it more painful for her and more uncomfortable for her by sending her into the hospital repeatedly, but we would not be able to change the overall trajectory of her life expectancy. And I got a call from the professional guardian a number of months later that Ruby had died, and she really thanked me. And this conversation is kind of one of the things that crystallized why I give this talk. So in sum, if you take nothing else away from this talk, I want you to think of dementia as a progressive fatal illness. I would strongly advocate that we all consider palliative care at the time of any diagnosis of a fatal progressive disease, and that includes dementia. And I personally think that the palliative care conceptual framework and honest communication from the time of diagnosis through the entire illness is the best way to help a person and their family get the right care at the right time. I always advocate for treating the person and not just the symptom, and focusing on quality of life. Just a little shout out. Quality of life includes engagement in meaningful activity. It includes connection with others, and it includes good pain control. So then I have some references here, and then some references on dementia and suffering. And so I think that's the end of my slides. So Nirmala Dar asked, can you give a good definition of palliative care? So the National Hospice and Palliative Care Association do have a great definition, and really I think palliative care is supporting people's quality of life when they have a life-limiting or fatal illness. And then Nirmala Dar says most providers and families do not consider dementia as a terminal illness like cancer. How do we change this? Well, this talk is part of my effort to change it. I think we have to really just point out the obvious. The Alzheimer's Association puts out an updated list of statistics every year, and it just shows how common a cause of death dementia is and how it is increasing. And so I think the way we change it is one person at a time, as well as what we write and how we say things. And then we got another comment here. I always thought folks didn't die from dementia, that they died from because their immune system was compromised, or they got another sickness that actually killed them, or had a heart attack or stroke. How does someone actually die from dementia? Their organs break down. Well, so dementia itself is brain failure. It's chronic brain failure. Delirium is an acute confusional state, and I think of that as acute brain failure, and dementia is chronic brain failure. Most of the time when people, the most common single thing that is the final medical event in a person's life is a pneumonia. That is actually, when I was in medical school, they called that the old man's friend, because we always talked about patients as if we're all men. So they called pneumonia the old man's friend, because it actually was not a bad way to die, and because it was an extremely common way to die. So that is the most common last event. But the reason that people with dementia, the most common reason they get pneumonia is because their dementia has impaired their ability to swallow safely. So it really is the dementia that caused the pneumonia that caused the death. And so just like everybody who dies, you stop breathing and your heart stops, right? I mean, that's how we tell you're dead. But we never put those as the cause of death. Those are just the things that happen while you're dying and at the time of death. And so dementia is the cause of death, or a major contributor of death in many, many people. And in everybody who has it, it's a big part of the reason that they die. So I think sometimes we get very concrete and we say, oh, well, my grandmother fell and fractured her hip, and then she had surgery, and then she got pneumonia, and then she died. Well, that is very, very common. However, if your grandma had advanced dementia, that's why your grandma fell, because her brain wasn't working and she couldn't walk safely, and her judgment was impaired and her gait was impaired. So she fell, which led to the hip fracture, which led to her laying in bed. And then she also had dementia, so her swallowing was impaired. And so then she developed a pneumonia, and then she died. That is an extremely common story that we see over and over. And ultimately, the actual inciting total reason the person died was their dementia. These are great questions. Do we have any others? While we wait for other comments or questions, let's see. Oh, yes, we do. Where can we get a copy of the mini suffering state exam? Great question. Dr. Amanoff and his group have given me permission and given everybody permission to copy the mini suffering state exam. In the reference list of this presentation, I have multiple references that have that within it. So it's easy to find if you Google it or whatever your web search of that you prefer. So it's easy to find. There are references in this presentation as well. Have you done anything with music therapy with dementia patients for pain and adverse behaviors? So music therapy, there's decent evidence that it helps a certain percentage of people with dementia most often for while the music is occurring. There is very limited, if any, evidence that the benefits, you know, would be there, say, 5 hours later or the next day. But in particular, I think music therapy is very important for our emotional state. So I think music is very important. It turns out that the music that was popular when we were teenagers is the most helpful music for us as we get older. It just shows you that no matter how much we change, sometimes we don't change. As well, frontotemporal dementia in particular, a lot of times people will be able to sing when they can no longer talk, because singing is in a different part of your brain from talking, it turns out. So there's decent evidence that music can really support a person. I think specific music therapy, there's less evidence of that, and there's no real good evidence that it has a long-term impact. That's one of the main benefits that medications have, because they're on board and they stay on board. However, if you have frequent, if you have a lot of music where you're living, that can be very helpful to people. What is the best practice recommendation on length of time to treat pain before looking to add antipsychotics? So I use the Pain AD, and I use that for treating pain, and I use antipsychotics mostly to treat paranoia, suspiciousness, fearfulness, belief that somebody's killing people, or hallucinations. So those are the most common reasons that I use antipsychotics. I would definitely make sure people were on a therapeutic dose of opiates before I added an antipsychotic to somebody. And if they're still scoring on the Pain AD, I think you can take that as good evidence that they still have pain. The Pain AD, where can we get a copy of that? As well, you can get a copy of that online. Why does swallowing get affected in dementia? So swallowing is impacted by your brain. Your brain controls swallowing. Okay, so what is available here locally that can serve palliative care? I'm going to defer that to Angela. Best ways to comfort individuals with dementia during end-of-life process. I think the key things to know about people with dementia is you want to avoid words. Although talking, the tone of your voice, the volume of your voice are all very important, but the actual content of your words is often less important for people with dementia. And I think all the ways that we comfort people, making sure the environment is the right temperature for them, offering them things, but not trying to force things on them. And one of the other things that's true about dementia is fewer choices are better. When people are really impaired, it's better to say, do this rather than do you want to do this. That asking people if they want to do something is very, actually stands in the way of getting people with dementia what they need. And can you speak to the spiritual and emotional pain and suffering for those living with dementia? I really highly recommend that you go to the Dementia Diaries, which is online. The site is actually, it's a British site. And I think that is one place that does a good job of speaking to that. There is very little evidence that mood stabilizers like Depakote have any impact in a positive way on agitation in people with dementia. What we know from the evidence is that people with Alzheimer's disease tend to have faster brain death, brain cell death, neuronal death, if they're on Depakote. If you know what Depakote does, it works on the inhibitory neurotransmitters of the brain. So it's like putting a blanket over your brain. And when your brain is already damaged, that can be dangerous. On the other hand, seizures are pretty common in people who have dementia. So if somebody has a seizure disorder, they might need something like Depakote. I have used Depakote when people have failed 5 or 6 or 7 other things, but I would never use it as first choice, second choice, third choice, or fourth choice, because it hastens the progression of dementia. What is the current data on palliative care being offered to dementia patients? It is low. I don't have any recent data on that specific question. Hi, Dr. Nash. When using the Beers list, what should one be mindful of when it comes to the use of antipsychotic medications? I would say if there is an indication for an antipsychotic medication, then I recommend using it. The Beers list has been misused and abused, and has been used to abuse patients and residents of long-term care facilities. It's very helpful. It gives you a list of things that may be inappropriate, but it doesn't actually help you at all with a single person and their problems. I recommend person-centered care, which involves assessing what does this person have, what is indicated for them, what are the risks and benefits for them, do the risks or the benefits win when you weigh them out. And I think what you're really looking at is the big picture of quality of life. So I think if you're using antipsychotics appropriately, then you should use them. I think if they aren't the most logical thing, or you're trying to treat something like sleep or appetite, those are not good reasons to use an antipsychotic. In fact, those are poor reasons to choose an antipsychotic. And in fact, that has led to people using, the most commonly used antipsychotic is Seroquel or quetiapine. And there is almost no evidence for its use outside of Lewy body dementia and Parkinson's disease dementia. There is no evidence that has any efficacy to treat people with Alzheimer's disease or vascular dementia or frontotemporal dementia. And somehow it got to be the most commonly used medication out there. And I think it's because it's like Benadryl. So, but that's a different story, and I'm running out of time. And St. Charles Health System does have an outpatient palliative care program that is separate from hospice. And so you can call St. Charles with the main number, and they can direct you to their outpatient palliative care service.